just welcome people as they join. Just a reminder, your cameras are on mute, so just make sure if you have something to say that you unmute it before you start talking, or we won't be able to hear you. My name is Heather Champney. I am a board certified pediatrician. I'm also boarded in obesity medicine, and we are going to spend some time today talking about childhood obesity prevention. Yes, we can get our slides up. All right. Okay, great. So, like I said, my name is Dr. Champney. I have nothing to disclose, the typical disclosure statement. I am receiving an honorarium for this lecture as a part of the Baby Steps grant, and I appreciate the opportunity to share some time with you all today and some of my knowledge and experience. My other disclosure is that this is not like a magic bullet. If it was, then I would be telling you this from some beautiful remote island because I've made a lot of money and solved this giant issue. So this is really just meant to be an overview of some things and hopefully to add some tools to your belt when we work to address this really giant problem. So there are lots of things that we could talk about today. It was really difficult to narrow down things that would be really helpful in this setting. So we're going to do it kind of in a three-part sort of state. We're going to look at just a really, really short review of some statistics. I promise we won't belabor those, but just a few that are pretty powerful data points. Then we're going to spend some time looking at this endocrine organ that we love to hate. So we probably learned a little bit about the biochemical processes of fat breakdown and lipogenesis in medical school, the Krebs cycle, all that sort of stuff. And we learned a lot about the disease processes that are a result of excess adiposity, but we didn't really learn about the actual endocrine organ. So we're going to spend some time learning about that, and hopefully that'll help give you some extra tools when you're approaching that patient. And just like with our ACEs discussion that we had from our last lecture, I think it helps really, if nothing else, just fill our compassion cup a little bit when we're talking with our families, and hopefully give us some tools to have these discussions. Then we're going to spend some time looking at different resources, because there are a ton of resources that you can Google and be overwhelmed with, but there's some really good resources out there that can help you engage these family discussions about behavior modifications that are evidence-based, and they're pretty powerful, and I'll show you some different ways to access those. So that's kind of what our goal is going to be. If you have any questions, feel free to chime in, and we will conclude with a little case discussion to go through those resources. So childhood obesity, we all know it has both immediate and long-term effects on physical, social, and emotional health. We know that children who suffer from obesity are at a much higher risk for chronic health conditions like joint problems, asthma, sleep apnea. We're now seeing a lot more type 2 diabetes in our youth population, increased risk for heart disease, that sort of thing. We also know that children who struggle with obesity are often bullied and teased more often than their normal weight peers. They suffer from social isolation, depression, and lower self-esteem at a much higher rate than their normal weight peers. And you may encounter patients that come into you for that specifically. And then in the long term, this is obvious, but children who suffer from obesity are much more likely to be adults who suffer from obesity as well. And they're at a much higher risk for all of these metabolic disorders that cost us tons of time and money. Things like type 2 diabetes and other metabolic syndromes, as well as some types of cancers. So the percentage of children affected by obesity has more than tripled since the 1970s. That's a pretty astounding increased rate of this disease process. And there have been some studies that have come out, popping across our screens in the last couple of weeks about a slowing in the trend, and maybe we're doing better. There are just as many studies that say that's not really the case. So just from 2015, 2016, it shows that 1 in 5 school-age children or young people in the US has obesity. And then these longevity studies that are produced by the CDC and some other entities predict that the majority of 2-year-olds will have obesity by the age 35. So these are current 2-year-olds, and the majority of them will be obese by the time they're 35, which is pretty horrifying thought process there. So obesity is defined as having excess body weight. We all use this BMI as our most convenient, although probably not the most perfect tool for measuring weight. This is just the general overview. This comes from the pediatric obesity algorithm that is supplied by the Obesity Medicine Association. And we'll take a little closer look at how to access this and some more of what it includes later. But here are the definitions that we're all familiar with. We know that BMI is the weight in kilograms divided by the height in meters squared. And we can readily track these sorts of things over time and plot them on growth curves. Consuming more food, more energy from foods and beverages than we use for healthy normal development leads to that slow and sometimes rapid weight gain. We know a lot of things play a part in this. There are many things that have a role in this disease process. Genetics, we can't do a lot about those genetics from the primary care office, but metabolism, how the patient's body actually uses that food and oxygen and turns it into energy. Then things like our community environments, so the design and safety of the neighborhood. We know that shorter sleep durations have really been a trend over the last 20 to 30 years, and shorter sleep is also associated with obesity, and then just plain simple eating and physical activity behaviors. The thing is, we as practitioners can't influence every single part of this, and it seems like a really overwhelming burden to bear, and that sometimes it's easier just to not talk about it. But really and truly, we're going to look at these things, but you do have the power to impact change just by having small, directed conversations with your patients. So don't let a lot of these statistics completely overwhelm you. So let's take another little look. I apologize, this slide, for some reason, when I uploaded it, it turned black. It was really pretty in blue before with numbers that you could actually see. But down, the take-home message is that these are percentages. This is from the Youth Risk Behavior Surveillance System, and they monitor a variety of health behaviors in youth. So high school students report, among other things, they report their height and weight, and from that their BMIs are calculated. And the higher the number on this graphic, the greater the percentage of youth that suffer from overweight or obesity. So 19% is where Tennessee falls, and you can see that our neighboring states, all of our friends down here in the stroke belt, this is not the number we want to be winning. We'd like to be a little bit lower. The thing that I would add, though, is that today the states that suffer from the lowest rates of obesity are still higher than the highest rates of obesity from our states and our heavier burden states from about 20 years ago. So even though there are states that look better than our state, all of the states are really not doing very well in terms of obesity. So obesity in rural America, we know, because this is our primary area of practice, we've seen this, and lots of studies have shown these trends of folks who live in urban areas having a lower rate of obesity than those in rural areas. This is a newer study out by the CDC, I think really just within the last couple of months. It really actually, rather than giving us a lot of answers, it raised a lot more questions, and we're not going to talk about all of those things. I just wanted you to see this graphic that across all of the groups of folks that they measured, youth, men and women, across the board, folks who live in rural areas suffer from greater rates of obesity than their urban counterparts. Some think that this is because there's a higher than average consumption of things like fried food and fast food in what's referred to as the stroke belt, which is us, Alabama, Mississippi, Arkansas, all of our southern friends. And then other studies have shown that living in isolated areas really limits the access to fewer healthy food options. So things like food swamps, where you have lots of fast food and you're doing your grocery shopping in the Dollar General, makes it such that the access to healthy foods is much more limited. One of the more surprising things and really concerning things to come out of this particular study is that youths in rural settings have a higher rate of severe obesity, and almost 5% greater rate of severe obesity, which is defined as a BMI of 40 or greater. And that's a pretty striking piece of information there, I think, and really drives home the point that those of us practicing in these rural areas really have to hit this a lot harder, a lot earlier. Across all of the youth and the adults, didn't matter where they lived, urban or rural, higher rates of obesity are connected to age of the head of household being an older age, and the head of household having a lower level of education. And another thing that also kind of spans this rural and urban divide is that obesity is more common in non-Hispanic Black and Hispanic youth than in their non-Hispanic white counterparts. And some of that is cultural, and I'm sure you've experienced that with your various patient populations. And we're not going to talk specifically about that because frankly we could talk about that for an hour. But that's just another little piece of some data to get us all on the same page. So, like I said before, in medical school we spend a fair amount of time in biochemistry learning about the Krebs cycle and fatty acid oxidation and all of those sorts of things. And then we spend a lot of time later on in pathology and in our clinical rotations learning about the side effects of too much fat in our bodies. But we don't really spend a whole lot of time learning how fat actually works, how it actually functions. So we're going to spend some time today looking at that. We're going to do a little bit of a history lesson, which is helps us sort of come to the point where maybe we have a better understanding of how we value or devalue fat in our current society. For centuries, fat was thought to be just a storage device for extra calories. You eat a lot, you get chubby, you starve, you get thin. But thousands of studies have shown that that's not necessarily the case, and that fat or adipose tissue is actually a very interactive and dynamic endocrine organ, and it has life or death influence over us. So the embryo at 14 weeks gestation starts to make fat, and this is before even all of the other systems are functional. So it's a really important part of our ability to function. So the quest to understand fat can be traced all the way back to the ancient Greece, where physicians believed that fat was a concoction of congealed blood, and it occurred more frequently in the quote-unquote cold bodies of women. It was hypothesized for years that fat was made from bodily fluids, and there were actually some very early associations between that excess body fluid and infertility. So fertility issues that probably were early PCOS and early low testosterone that can be linked to excess adipose tissue. And then Galen was even, he made sort of that connection between fat and food and energy, and he proclaimed his ability to use exercise to, quote, reduce a huge fat fellow to a moderate size. So we're going to spend a little time talking about some of these ways that fat is actually our friend and how we have discovered that over the years. We're not going to talk about every single one of these though. So the advent of the microscope in the 1600s is when we really started to have a deeper understanding of fat. We recognized that it wasn't just this fluid sort of thing, that the fat was comprised of vesicles, which we later know as cells. But the unique thing about these cells is that they have the distinct ability to store fat, and they can store lots of it. They can actually expand their volumes to more than 1,000 times their normal size by pushing other cell contents off to the side, and that is unique to fat. Molecular theory further helped us understand what fat tissue actually is. So from that, we learned that a fat molecule is a long chain of carbon atoms. There are different types of fat molecules. Collectively, we call these lipids. And then we classified the actual structure of that body part that is fat, our adipose. It's composed of these fat cells, these adipocytes, and they store millions of fat molecules that can be used for energy. But it's also not just fat. So about 3/4, if you were to pinch an inch, only about 3/4 of that inch is actually fat cells. The rest of it is collagen, veins, nerves, blood, muscle, stem, and immune cells. But we're going to focus a little bit on some of those other properties of fat here in a minute. So in 1936, scientists, which really wasn't that long ago, so that this was pretty recent, that scientists were actually able to trace how carbohydrates from the food get shuttled to the liver, and then they get turned into fat molecules. Some of them do. Then these molecules are sent out via the bloodstream to the fat tissue, and they're deposited there as triglycerides. And then about a decade later, so in the mid-40s, it was discovered that adipocytes could actually make their own fat. So they have the ability to produce themselves. So, quick reminder of what happens when we eat. You take in food and insulin is released from the pancreas. And that insulin is telling the body, hey, nourishment is coming, get ready to use it or to store it. And you can think about this energy or this fat as a type of currency. And I like this example because it's a really nice way to put it in relatable terms for your patient when you're talking about these sorts of things. So glucose is like our quick cash. We can have it ready and available for immediate use. Glycogen is like our checking account, so we can access that pretty readily. We don't have to work too hard to access that. And then fat is our long-term energy deposit. It's our certificate of deposit, so to speak. So after a meal, your glucose levels climb, and we peak those out, and then we increase our glycogen levels, and we stock up that checking account. And then all of that excess stuff, excess carbs, sugars, fat, protein, they go into the liver, and they're converted to fat via lipogenesis, and they're stored in our adipocytes, our long-term storage deposits. So that's just an easy way. I've used this with patients, and it does seem to really resonate with them when just explaining how fat and how our body uses energy. So fat does all the things, as I mentioned before. The first little graphic up there is a graphic of the two types of fat that we have. So white fat is the type of fat that we all love to hate. That's the fat that stores energy. That's where we store all of our triglycerides. And then the brown fat is something that we associate more commonly with babies. They have a higher percentage of it, and that is fat that actually burns energy for heat. You activate that type of fat when you're shivering, for example. And there's some really cool areas of research looking at, there's a different type of fat called beige fat, which seems to be a crossover between those two, and we won't talk about it, but there's really interesting research about taking brown fat and injecting it into white fat to help us burn more energy. Fat literally holds us together. It stores energy, it's used for heat, but every single cell membrane is made up of fat and carbohydrates. It's critical. So myelin, for example, is made up of 80% lipids. So you literally need fat to think. We also know there's different types of fat molecules in the body. So as early as the 1920s, we made this discovery, and we're not going to belabor the process through which this is actually a husband and wife scientist team, but at that time, fat was thought to be completely unnecessary in the diet. So they deprived these mice in the laboratory of fat, and they discovered all of these side effects that the mice had, and they eventually died if they didn't have any fat. So long story short, this was when they discovered linoleic acid, which we know doesn't store calories, doesn't have anything to do with that, but it's a signaling molecule that suppresses inflammation. This then set them down the path, once scientists accepted this, of the discovery of the whole group of eicosanoids, which are all short distance messengers and have nothing to do with calories. Problems with that type of fat and those type of molecules are linked to inflammation, cancer, arthritis. And then one of the, especially in pediatrics, since we're treating fevers all of the time, one of the most studied of these eicosanoids is prostaglandins. And We know that those sensitize our bodies to pain and induce fevers. They also play a role in pregnancy and labor induction. So fat has a lot of roles that it plays. So moving down the decades, and I promise we're getting closer to today, in the 1970s on, we discovered that fat really, in addition to those things, it can talk. So it is a big hormone endocrine organ. Again, I'm not going to go into all the details about how this was found. It's really fascinating the way that these discoveries were made, and they were done both in the laboratory and comparing patients who have really severe malfunctions of their adipose tissue. But basically, through laboratory studies with mice, they discovered the OB gene, which is the obesity gene. And this gene we know now codes for leptin. Leptin comes from the Greek root of leptos, which means thin. And leptin is released from your fat tissue, and the amount of leptin that is released is directly related to the amount of adipose tissue that the body has. And it goes up to the hypothalamus and serves to suppress hunger. So it is our satiation hormone. It's what tells us that we're full. Since then, which was a landmark discovery, leptin was the first one, we have learned all of these other hormones that fat tissue produces for us. And we're not going to talk about all of these, but the one that we know the most about is adiponectin. And we know that it has a significant role in healthy fat distribution, among other things. And these are all hot topics of research. We know that fat is vital in puberty, both male and female. It's vital for the maintenance of pregnancy and breastfeeding. If you'll remember a long time ago in immunology, and that our stem cells in the bone marrow, the same parent cell can become either a fat cell or a bone cell. So they share the same parents, and things such as body weight are the things that drive the differentiation into either bone or fat. We actually know that weight is a better predictor of your bone mineral density than your age. So postmenopausal women are really reliant on fat to protect their bone, because that fat tells the bone marrow to turn those cells into bone and to build up those bones. And since our ovaries quit producing it, fat also then becomes the primary source of estrogen. We could go on for days about the positive roles that fat plays, from brain function to cushioning. It has a role in longevity. And those are some really interesting things, but we're not going to go into tons of detail about that today. This is where we want to focus a little bit more, and the role that our fat plays in our immune system. So fat communicates. It actually has its own immune cells, and that is really great when we have cuts or infections, and the fat recruits those protective cells and helps us heal. But when fat activates the immune system chronically, this leads to metabolic diseases such as diabetes. In the early 1990s, it was discovered that the fat of obese animals have a much higher burden of tumor necrosis factor alpha, which is an immune system stimulant. So you think that should be protective, but very high levels of tumor necrosis factor actually interfere with insulin signaling. So then too much tumor necrosis factor doesn't allow our cells to properly metabolize sugars. And this interference happens in the fat cells, but it also happens in the liver and in the muscles. So it makes all of our cells insulin resistant, this chronic inflammation, and this chronically high level of tumor necrosis factor. So to condense a lot of stuff here, so the fat cells in lean animals contain about 5% macrophages. The fat cells in obese tissue contains about 50% macrophages. And one theory to explain this is that when our fat cells get really full and there are lots of them, it gets crowded, and this is really stressful for the cells. So it decreases the supply of blood, the flow of oxygen, and this reduces stress. So then these fat cells that are all stressed out signal distress in the forms of cytokines like tumor necrosis factor alpha. And the immune system sends even more immune cells to those stressed out fat cells. And you have this really chronic sort of cycle of stress, increased immune cells, stress, increased immune cells, all of which are leading to insulin resistance. Then when this happens, when you don't have insulin, as we all know, but probably need a reminder, insulin is what tells our cells to take up those nutrients. And when our cells don't respond to that, our pancreas compensates initially by just turning up the volume. So it pumps out more insulin trying to get these cells to respond. But that inflammation keeps those cells resistant, and then eventually those cells stop responding at all. And then eventually your pancreas kind of effectively burns out because it can't keep up with that rate of production. Then you get cells that won't take up sugar and they won't take up fat, and they circulate in the bloodstream and they get deposited where they should not be. So in the vessels, around the heart, around the organs, and they cause all of this disease processes that we're familiar with. So the take-home message is that obesity and folks that suffer from obesity, it is not a lack of willpower. And I think that is something that's oftentimes our default, and it has been for many years, that a patient suffers from obesity because they can't put down the potato chips, or they can't choose to not drink soda. And really, while there is personal choice involved in this, it's not a lack of willpower. It's truly a hormonal imbalance, and it's mediated by our immune system and this chronic inflammation. So it's a pretty powerful cycle that we have. And really, probably now, we have this exposure to really high insulin and to increased inflammation really starting in the womb, which is some of the thought to explain that early childhood obesity. Is that we have insulin just chronically circulating from the mother through the placenta to the child, and we know that insulin is our obesogenic hormone. So when we have this from a very early stage, we're fighting an uphill battle from the very beginning. We could keep talking about this. We could actually talk about these things for days. Things like the paradox of weight gain and loss. Our resetting of our basal metabolic rate slowly over the years, because our body really is going to fight to keep that fat on. Someone who has always been normal weight has a much easier job of maintaining their basal metabolic rate than someone who has yo-yo dieted, had increases and fluxes in their weight, because once you have increased to a certain weight, your body has that set point, and it's going to fight to keep that set point. Also, once you lose fat, you lose leptin, which is what tells us that we're full. And then we could talk for days about the other things that play a role in our reward centers and hunger centers, and how things like highly processed carbohydrates, high fructose corn syrup, those sorts of things don't ever tell us that we are full. So those chronically hit our reward centers and stimulate that. But that would be a whole nother talk. So let's move on and talk about just some practical resources. So can we click over to the thing? One of the resources that I wanted us to look at is the Obesity Medicine Association website. So this is what you'll see when you type this link in. It is run by the kind of main folks in obesity medicine, and they have a ton of resources on here. This is how you can go through the process of becoming boarded by the American Board of Obesity Medicine. They have lots of things you can use in your clinical environment, especially tailored towards the adult who's treating obesity. So these little infographics and that sort of thing are really pretty interesting. But what I wanted to point out is under this clinician resources, they have a whole bunch of stuff, but they have the obesity algorithm, which is treatment of adult obesity. And then they have the pediatric obesity algorithm that we'll look at a little bit more closely in a minute, which is again, treatment of obesity in pediatric patients. And then right here is our pediatric resources. And let that load. So this is a nice, it's constantly updated. It is a kind of catch-all. So if you're walking into a patient's room and you need a refresher or you need some handouts, it's broken into physician and family specific. You can pull this up in the room with the patient and show them some of these links. We're going to look specifically at a few of these in more detail with a case presentation in just a minute. But what I wanted to see, can I move this down so I can see this? Whoops, what did I do? Go back. So there's a few things I wanted to look at specifically without clicking through all of the things. You can get to all of these things I'm showing you from that pediatric obesity resource page. But the AAP has developed the only online module training for engaging in conversations with your patient regarding obesity. And these are really good, actually. They're evidence-based. You can actually download it as an app on your phone, and it works pretty well, actually. These are, I think there's 4 or 5. They've added a few more recently. It's all based off of motivational interviewing practices, and it lets you have these sort of real-ish time conversations with patients about their weight. Because oftentimes, as practitioners, we avoid that sort of big obvious thing in the room, and this just gives you an opportunity to practice. It's the only online evidence-based module that's available, really, I think, anywhere, from what I understand. Now, Brian, how do I see underneath to look at these other? Thank you. We are going to spend some time going through this half in just a minute with our case scenario, but I wanted to show you another thing that's provided. The Ohio chapter of the AAP is pretty dynamic, and they have a lot of great resources. But this is another thing that you can pull up in your office. I think they even have a way that you can give some patient handouts, but it's a parenting at mealtime and playtime. And it is, again, an evidence-based program that has had really positive outcomes. And there's an app that you can't pull up on the screen here, but you can pull it up on your phone, and you can interact with that with patients in the room. And I've used it successfully in the emergency room, which is not a primary care setting, but so many of my patients are in there for dietary related issues, aka constipation. And so we have these pretty great conversations using just my cell phone. And most patients have access to a cell phone. So that's just a resource I wanted to point out. And then another one that I think is really great, and I just want to move up here and live with this woman for a while. She is a pediatrician in Virginia, and in her building, one half is her general pediatric clinic, and the other half is this teaching kitchen, and it has this big, huge garden outside. And she does a lot of things with the really early childhood, a lot of homeschooling and preschooling. And you can see here she's got all of these resources: preschool nutrition, there's a blog, there's a really great meal planner that has some awesome recipes and very, very simple, easy things to use. My caveat with this is that your patient, the parent, does have to have some level of literacy to be able to interact with this in an effective way. It's still visually really beautiful, and they can interact with it, but it's probably not going to be the best for your lowest of educational levels. But again, it's a great resource. Another thing, a book that I love, and it's written by her. She co-wrote it with a speech language pathologist who is an expert on disordered feeding. And it is, you can buy it through here, but it is called Raising a Healthy, Happy Eater. And it truly is a almost minute-by-minute guide for the parent of feeding techniques and how much the child should be expected to eat, and et cetera, et cetera. Again, there needs to be a level of literacy to actually interact with the book in a reasonable way, but even if you just ordered it and had it sitting in your office and you took a look at it yourself, or you took it in to show the parent in real time, just some tips and techniques and common pitfalls of feeding the 6-month-old and 18-month-old and that sort of thing. So again, this is just a resource that I think has a lot of legs for certain patient populations. Can we go back to the PowerPoint for a second? Thank you, Brian. Okay, so I wanted, because it's too cumbersome to do, you have to actually download it from the Obesity Medicine website. So I pulled just a few slides from the pediatric obesity algorithm. Like I said, you can download it for free. You can actually even order, it's like a little spiral bound flip notebook that you can have. It's just as simple to download it to your computer though and have it at your hand. And what it is it is really meant to give clinicians who are not practicing obesity medicine exclusively, who are not in a big center, that don't have tons of resources. It's meant to be a quick way to look and see the guidelines based off of age and all sorts of things. So it's developed by all of and actually I think it was all women that did this. They're all board certified pediatricians, several are board certified in endocrine medicine. The lady who led this is an adolescent medicine doctor who runs an obesity clinic in Texas. And these are some really dynamic and amazing folks that have developed this. It's a working document, so it's always updated. Some of these slides didn't translate very well over for some reason, so I apologize for the way some of them look, but this is the table of contents of what this document holds. So it really is a pretty comprehensive, if nothing else, starting point for those of us dealing with obese patients in a setting where we can't access all of our high-level resources. So it goes through everything that you could possibly need. And here's just a few examples. So you've got an infant coming in that was a little bit big the last time they were in. So here are some of the history questions that you might want to explore with your patient. This is just a quick way to look and remind yourselves of the questions that you need to ask. It has general resources for intake. It also has a similar thing for physical activity, and it spans the ages. So this is just the one for 0 to 12 months. And it shows you all this. It's actually really nice to be able to show this to a parent too, so you can take it in on your computer or order the little flip chart and show this to them. And it's I think a really powerful way to help people understand how much or how little, depending on the case, that intake is actually needed by age. And then, so we're gonna, I listed these here so that if you access this specific PowerPoint, you can get to these resources pretty quickly. They're all on that pediatric resource page. So what I'm going to do first is read through this case scenario, and then I thought we would go to our Healthy Active Living for Families and explore how that website can help us with this particular case. So let's see. Yeah. Cruz is in for his 15-month well child visit with his mother, Ricky. He's at the 90th percentile for weight and 50th percentile for height. So again, remember he's under 2, so we're not calculating his BMI yet, but we can see that he has a greater percentile of weight than he does height. He started cereal at 3 months of age, and he loves food. He is a great eater, and he loves his cereal in the bottle at night. He eats cereal for breakfast. His favorite meals are, surprise, chicken nuggets for lunch, and he likes tacos and beans for dinner. He does eat some vegetables, eats fruit, drinks juice, milk, and an orange soda at his grandparents'. He has an easygoing temperament. He likes to play in the park with his mom. His grandparents keep Cruz while mom's at work, and his grandmother has mobility issues, so they stay in their apartment a fair amount. He doesn't watch very much TV. Ricky, the mom, struggles with her weight, and she and her husband live in the same apartment building as both sets of grandparents, as well as some aunts and uncles. So there's a lot of family influence into how this baby is fed and a lot of shared caregiving. So I wanted to go to, can we actually just go to that? Thank you. I keep forgetting to do that. So FAAP is again another program produced by the AAP, and it's really a pretty amazing program. It is very evidence-based and validated. They worked with parents of young children and practitioners to gather this information and really guide the evidence behind the information that they provided. The parent feedback was done through 2 focus groups that kind of initially formed it and then evaluated it. The interesting thing I wanted to point out on this is something that we all, I think, intuitively know, but most parents believe that childhood obesity is a serious problem, but most of them assess their own child's weight as just right. Whether they've been told by whomever that it's not, they do not have, they have rose-colored lenses, shall we say, looking at their own child. And then most of the parents identified their pediatricians as their primary source of well child care. With relation to obesity prevention medicine messaging, so parents really don't like associating infancy with obesity. They just don't like it. It doesn't feel right. And so using some of that terminology can be a turnoff, saying your 2-month-old is obese, which sounds ridiculous, but it does happen, turns the patient off. So it really impedes the provider's ability to connect with the patient using just some of that not patient-centered terminology. And then focusing on future outcomes has become really imperative, obviously, but that seemed to resonate more with parents. And then parents also tend to say that their personal experience is just very incongruent with the expert guidelines and guidance. So they feel like it's maybe not realistic or attainable in their environment. So these are some tools that we're going to explore here to show ways that you can use this to engage your parents. So we have all of these different things. We're not going to go through all of them. The Communicating with Families tab, if you go there, it'll explore some of the ways that they developed their communication tools, and also talks about motivational interviewing and some resources to learn more about that, like I showed you with that other resource. What I wanted to show, though, was this half recommendations by age. So this makes it really simple, actually, to sit down with your patient or to look at these things before you go in. So before we look at cruise, I just wanted to quickly show you under the infant tab. So you can go and it tells you your desired behaviors, what you're looking for that age range. Exclusive breastfeeding for this first 6 months, continue breastfeeding until the baby is 1 or it's mutually desired by the mom and the baby. And then it goes through the evidence showing how breastfed babies are less likely to be overweight, that the duration of breastfeeding is related to the risk of obesity or inversely related to it, that a reduction in type 2 diabetes is reported even in the setting of overweight and obesity. The longer they breastfeed, the less likely they are to have type 2 diabetes. I think this one is really, really important, that 80% of mothers expect to breastfeed, but only 14% are exclusively breastfeeding at 6 months. And then it reminds us of those critical transition periods for when moms are going back to work or when those babies are going through their growth spurts. Then it tells us some parent feedback that was gathered from those focus groups that I mentioned, and that breastfeeding was a lot harder than they expected. They tried it, but they didn't actually maintain it. But many were surprised to learn that breastfeeding can impact obesity and felt that that might have impacted their decision around the duration of their breastfeeding. Then opportunities for care. So here's some different ways that you can support that mom, et cetera, et cetera. I really love this tab, the conversation starter, especially for providers who are not taking care of pediatric patients exclusively, or maybe you have a family practice and you're seeing a whole family and you've got to deal with multiple ages in the room at the same time, including mom. Here are some reminders of things that you might want to bring up at the 2-month visit or the 6-month visit. And then there are some resources. And this goes on down through bottle feeding, food introduction, snacking, self-feeding. It goes through the whole shebang. So let's remind ourselves, Cruz is a toddler. He's in for his 15-month well child visit. And we're just going to go through the things that we would see if we looked at this before we went in to talk to his mom. And then I'd like for anyone to chime in and just say how they would approach this patient. The timelines are really kind of interesting, and I think fun to look at. So you can just go down through and it tells you these pitfalls. So at 12 months, they start sleeping a little bit less. They've had too much TV exposure, et cetera, et cetera. So this just is a reminder and a nice visual It's kind of an interactive visual the way it pops up, and you can show this to parents because it's not just you talking, it's a different way to interact with the material. But let's look at why. So remember, Cruz is 15 months old. He's at the 90th percentile for weight and 50th percentile for height. He's cared for by lots of well-intended family members, and he's given quite a bit of sugared beverages, for example. So you might think, all right, what's the evidence that we need to reduce this? So juice contributes an average of 100 calories a day to a toddler's diet. That might be a point that resonates with Mom Ricky that you want to bring up. And then what's the parent feedback? Maybe parents support that message, but they find it really difficult to set limits. They also don't realize that juice is unhealthy. They're confused by the difference between juice and 100% juice. And they think that juice is a way to get another fruit and veggie serving in. So these are just things that I would look at specifically for Cruz when we are talking to this mom. So, it's like 12:47. Does anyone have anything they would like to add for this, how they would present? Dr. J's here with us now, so I'm looking at her.
Well, I'll come sit there, so I'm heard, I guess. I was on the phone for a little bit and then I'd come in and out of the room, but I think the conversations with juice are particularly difficult. I think part of it is one to expel the myths, like you said, they think juice is healthy, they think it's a fruit, and they think that, it's fine to do it. So I think that's part of the first step. But what I find most successful is sometimes even giving them an immediate disadvantage, if you will, like the tooth decay usually seems to catch their attention. And so, apart from, like, I'll start the spiel with, we really used to think juice was good. 20 years ago, as a pediatrician, I would probably ask you, how much orange juice have you given your child today? Or how much, because a lot of times it's a grandmother in the room who remembers a time when we as pediatricians actually told them 6 ounces of orange juice every day, 8 ounces of apple juice every day kind of thing. So I'll say we may have asked you that, but we've realized now that it's unhealthy, it has too much sugar, it really is not helpful at all. And then one of the biggest pieces that really concerns me is sort of tooth decay. And usually that seems to at least catch their attention. I don't know your experience with it.
Well, and that's one of the things on there that was mentioned as something that caught attention. Under the evidence that parents, that resonated much more than just it's too many calories. That didn't seem to have the same resonance as your teeth are going to fall out. So that seemed to have more meat to it, shall we say, with that. I don't know who else is logged into our session. If anybody else here is practicing. I want to see some other people.
I see Sarah. Yeah. I think Lee was there.
I can't tell who's else, but does anybody else have anything they'd like to add or contribute about this case, or just in general? Hey, little guy. About your interactions with patients when discussing these sorts of behaviors. And
I don't have anything specific other than I do talk about sugar drinks and how I recommend they drink mostly water only between meal times. Only get. Can you hear me?
Yep.
Yes.
So there's a weird. So that's only water. Milk, using no more than 4 ounces a day is what I say, because of tooth decay and all the sugar isn't good for them. And most people are pretty receptive to that. And since I've been doing that for several years now, some of my patients, I think it's pretty effective. And the younger kids often will tell me they don't even drink juice. They don't like it. They don't want it. So it's kind of a learned behavior. So that's kind of interesting to me how many parents are willing to listen to that, which is encouraging.
That's great. Yes. because that's something I think we can really impact. We can't impact all of the other factors, but gosh, if you could get them to quit consuming 200 or 300 extra calories a day, you're making some impact. Anybody else? Anything?
This is Matthew. I think sometimes it's hard for it to change habits for toddlers or a little bit older kids if it's really ingrained in the whole family as a health habit, because then you're asking that one child to have a totally different diet than the rest of all of the family has, which I feel like it's difficult unless we can engage mom and dad sometimes to change that behavior too, especially for little kids. If there's plenty of unhealthy snacks around and accessible, it's hard to just, I think, focus on that patient without treating the family as a whole.
Totally. I mean, my practice, which is not primary care, but I end up addressing a lot of primary care issues, that's typically rather than talking about the patient specifically, I talk about the whole family in ways, little tiny things that the whole family can do to change their behaviors. That all together, everyone is going to try and drink 2 extra glasses of water a day and start off with something that's a positive rather than everybody stop drinking juice today, but increasing the water with the goal of, hey, 2 weeks from now, let's decrease that juice or that soda down to 12 ounces a day. And give them some real timelines of tiny, little, very achievable and maintainable habit-forming behaviors. And I think that works. I mean, I'm in the ER, so I can tell if you come back that you haven't been listening. But my follow-up is a little bit different in that setting. So that's what I use.
I think one of the frustrations or the difficulties that I've experienced is if you make even these small changes in one area, the family might improve and drink a little bit more water, but then it's like compensated in other ways, like, oh, well, they've been eating out more than they used to, and then you work on that little piece, and then there's another piece that comes up, and so it seems hard to have these small, measurable, objective goals when it's so multifactorial and so many things impact kids' weights and families' health. It almost seems futile, sometimes in primary care, where you get a really good program going and then there's like 3 or 4 other health behaviors that are negatively impacting that almost outweigh the progress it seems like that's been made. So I don't know if you have any comments about like how to address all of these things, or if you should still focus on one piece or not.
Well, the way I typically approach patients is that really broad sort of thing. I talk about the disease process. So I do a lot of work to remove blame so that we can have a conversation that is not an indictment. And I really use a lot of motivational interviewing techniques of, what are some problems that you see? Can you tell me a little bit about your family's lifestyle? And then I tell them some, maybe not to the detail that we talked about it, but I tell them some about the physiology of weight gain and the way our bodies hold on to it, because it removes that sense of I'm not worthy, I'm fat because I don't have willpower, or I can't make these healthy changes because there's something inherently wrong with me. And I have found that giving them some basis that says, hey, these are the physiology sorts of things that you can influence, but you can't utterly control. That you're not morbidly obese because you're a horrible human being. These are some of the things, and I have found that those conversations, at least the conversations, are a lot more effective. If I start off with, this is a disease process, I'm not blaming you for your cancer, so I'm not going to blame you for your obesity. We're going to talk about the process by which we become obese and the way that our bodies fight to hold on to fat, and then the ways that we can influence that, and that it's really hard, that it's a really hard sort of thing, and that you may not see big drastic changes, but making small little changes will influence it. And at least from our conversations, I have found that once I sort of changed that, my approach to it, and was much less patriarchal in my do this, and that'll solve your problems, we've had much more engaging conversations. So And that seems to be where the evidence is right now too. You see patients on.
I would agree. And I think what you said, Heather, about you've done it so long that you now do see a difference in some of your families, I think is a very pertinent point. You know, yes, it's very hard, like Dr. Tolliver said, to approach a family that has a teenager and a 5-year-old and then now a toddler, and the teenager and the 5-year-old may be set in their ways and there's the availability of everything already. But the more fresh and new young families that we can influence and make them understand that, hey, this is too many calories, juice is not good for you, here's why you wouldn't do such things, here's why you would keep them active. I think the more that collective knowledge builds, and you know, the better it seems like we progress. Because I would anecdotally say too that in 10 years or more that I've been in this area now, I do find there are more and more families who will come back and say, no, we don't do juice at all. No, my toddler doesn't drink juice at all. And that was not the case 10 years ago. I mean, it was a norm. It was a given that they would get juice. And I think a systems approach to some of these things is also very important, as much as we tackle it on an individual patient level. I had one time a grandmother come tell me when I preached for about 10 minutes about juice and the bad effects of the sugar and the juice. And then she looked at took her purse and pulled out a coupon and said, so what do you want me to do with this? Just tear it up? Because if the coupon was from WIC and it gave them 52 ounces of free juice for the month. And, you know, to her, that was, they're giving me money here and food, and you're just wanting me to tear up this food? I don't understand what you're saying. And so I think understanding it from a systems perspective and really then approaching sort of our legislators and looking at it from a global standpoint, I think is also important, because I think the system is against us in fighting the obesity piece. Does that make sense?
Most definitely. And we could talk for days about why that is and how that's come about, and subsidy of corn and soy, and why we have such ready access to these highly processed carbs. And it wasn't all a conspiracy theory. It was partly to feed people that were starving. But there's a lot of money there. And a lot of these studies are funded by the Nestle Foundation and Kellogg Foundation and those sorts of things, where there's a direct conflict of interest really in changing these behaviors. So you're exactly right. Advocating, doing more than our individual practice, even if it's just something as simple as writing a letter or engaging in a community or a committee, you know, the Section on Obesity Committee through the AAP, or the Pediatric Obesity Committee through the Obesity Medicine Association. There's lots of other ways that you can advocate on a more global scale, I think. And yeah, that's definitely what we're going to have to do to make big changes, for sure. We have like a minute left. Does anybody else have any questions or anything they want to add? So this, I just brought these books. They're not going to be great, but this is the book that I mentioned that's from the Dr. Young project. So it's a pretty book. It's easy to use, and it's broken up, and there's tips from the feeding specialist and tips from the pediatrician, as well as just some general developmental information, which again is good for a parent. You can order these things in bulk actually and hand them out, but I don't get any money from them, just telling you. Motivational Interviewing in Healthcare. It's a nice read, and it's a really good basis for developing some of these skills. There are lots of online opportunities to do the same, but this is just a nice read that I had. And then a lot of my information from the talk and came from these two books, which are really good, and they are, again, actually written for the layperson to read or consume, pardon the pun. But they're really good. They're very good. The Secret Life of Fat. Sylvia Terra is a PhD biochemist and has done tons of research, both clinical and otherwise, into obesity and how our endocrine organ works. And then Dr. Fung is on the cutting edge of really treating obesity. He was a nephrologist and frustrated with all of the end organ disease that he saw, so he started doing this research. He's got a website. He's an acquired taste of the way he presents certain information, but it's really good information. So those were my little resources. And if you guys have any questions or you want more resources, feel free to email me. Thank you.
Thank you.
I'd like to add my husband's using the principles in the obesity code and has finally been able to successfully lose weight and keep it off.
Oh,
It's a great program. I mean, it's a really intermittent fasting and low carb or lower carb. It's kind of seems to be where it's at right now in terms of treatment and prevention.
I'm not sure how to apply it to kids though. I'm not sure what to tell them if it's okay to not eat breakfast, because we've been taught you have to eat breakfast, but my 12-year-old hates breakfast right now. So I've kind of said, well, eat when you're hungry, and then don't force her to try to have healthy options when she's ready to eat.
Can we have him come along every time? I like that. No, it is, and there is conflicting evidence, because we know babies need to eat at a different rate than older children and then adults. So yeah, there isn't a clear answer specifically of what age can you start doing that low carb or intermittent fasting. I think some of it's dependent on the child, and really if we listen and if we train our bodies early on to respond to our cues, then we will know. So your 12-year-old knows when she's hungry, so having a healthy option available at 10 a.m. Rather than force feeding at 7:30, and then they get a snack at 10, and then they get lunch at 12, and then they get another snack at 2. And so when you're eating like that, you're constantly exposed to insulin. You never have time for your insulin to actually fall. So then you develop that insulin resistance, even without actual obesity. So that constant exposure to food, the chronic snacking, we can impact that. We can help our parents make better choices in what they snack and how often, and that really meals should still be occurring and shared. So yeah, there's a lot of stuff that has to be figured out about when we can apply things like intermittent fasting.
So I had talked to one of my teenagers about it, that it's morbidly obese, and her BMI is probably 38, and she's probably 14 years of age. And so we talked about, if you're not hungry, then don't eat. And when you do eat, have high quality food and cut out the juice and the snacking. And she'd already cut back on her snacking but hadn't stopped. And so I felt weird though, talking about, if you're not hungry, don't eat, because we're trained so much to do the 3 meals a day. But going for the obesity code information, I felt a little bit more comfortable saying that, but still I don't want to get off in the weeds and recommend the wrong thing either. So it'd be lovely to have some of those principles explained in terms of adolescents, especially, who are more aware of their body cues.
Well, for sure. But part of the problem with the morbidly obese adolescent is that they've sort of already lost their hunger cues. And so they perceive lots of things as hunger that isn't hunger. So just telling them not to eat when they're not hungry probably misses some of it, because they probably perceive thirst or discomfort or other sorts of things as hunger. They trained their body, their reward center requires something, and it's in the form of food usually, or a sugared beverage. So it is, I totally agree. And there's some stuff, CHOP has a great adolescent clinic, Duke, and there's one other, it's listed on that OMA page. And they have some really good stuff for specifically for the adolescent with obesity and the 10-year-old with obesity and that sort of thing. So that might be a place to look and start having a conversation with those materials in hand to guide you more specifically.
this has just been a wealth of information, Dr. Champney. Thank you very much.
Thanks for coming and sitting next to me. I appreciate it. Thank you all so much. You can get my contact information from the CME office if you need to. Have a good day.